Good day. My name is Jose Santiago Esquivel, BSNRN, presenting a case of acute pancreatitis for a nursing 5223, adult and geriatric health theory 2. Our history of present illness, presenting a case on a 58-year-old Hispanic female presenting with epigastric abdominal pain and vomiting. During the interview, the subjective data gathering section, she did state increased stress and health issues at home, which led to her begin to increase her alcohol intake. And she was specific when describing up to 6 shots of vodka daily. Her abdominal pain was described as epigastric, non-radiating, sharp, which started 2 weeks ago, associated with vomiting and occasional diarrhea. The pain could be alleviated by rest, sitting in a supine, lying in a supine position, and also not eating or anorexia. The epigastric pain, she did state, was associated also after the intake of 2 antibiotics. She was on clindamycin and levofloxacin as a result of cat scratches, cat bites she suffered in recent weeks. The epigastric pain and vomiting gradually worsened, she reported, until she no longer could keep even fluids down. So she decided to seek medical attention. For the subjective data, she did present with history of hypertension, anxiety, also back pain, alcohol abuse, previous alcohol abuse, and chronic kidney disease of unknown stage. She did state she was not under any nephrologist care. Her social history did confirm, of course, she is married. She does live with her husband, who is disabled. And there was no specifics on the type of chronic illness he is suffering, but she did clarify living with her 2 daughters, who are also caregivers. Patient does deny smoking and illicit drug use, but again, just confirmed the increased alcohol intake of 6 shots of vodka daily. In her family health history, there's no contributory history by ancestry. Surgical history includes a bilateral knee surgery, C-section, and Bartholin gland removal. Patient is on 3 medications: cyclobenzaprine for her back pain, enalapril, and metoprolol for her high blood pressure. On the review of systems, she did deny any fever, chills, or fatigue. No recent vision changes. She denied any congestion, ear or sore throat, or ear pain. However, she did the only positives that we found on the review of systems. I found positive again for abdominal pain, the nausea, and the vomiting. However, she also denied any incontinence nor dysuria. In the physical exam, no acute distress was noted, of course, and her cardiopulmonary and gastro is where we find some interesting findings. The patient was tachycardic, but S1, S2 were normal and regular rhythm. She denied any palpitations. Upon auscultation, no murmurs or gallops noted. Pulmonary-wise, under pulmonary system, again, clear lung sounds upon auscultation, all fields. No rhonchi nor wheezes noted. And of course, on her gastrointestinal section of the physical exam, I did notice soft, slightly tender to palpation, of course, in the epigastric, in the upper quadrant area. Hypoactive bowel sounds to all 4 fields, all 4 quadrants. Extremities, she did not show any edema or cyanosis. However, I did confirm to her right leg lateral leg, of course, 3 puncture wounds consistent with the cat bites she previously mentioned. There was no signs of cellulitis, and there was slight darkening of the wound bites, but no purulence or any, or any erythema to that area. And neuro-wise, again, she's alert and oriented, and no focal deficits, and her psychiatric profile, again, she was normal affect and very cooperative, very good historian. I did notice upon obtaining vital signs, of course, the tachycardia was there. Her heart rate was over 100, rest beats of 20. She was slightly hypothermic at 35.9. And her blood pressure was still high, 155 over 85, and she was sitting on room air at 96%. Upon consulting with my preceptor, labs were ordered. CBC and CMP were ordered, of course. Lipase was ordered, as well as a UA, and CT scan of the abdomen and an ultrasound of the abdomen. My preceptor mentioned that it was wise and very prudent of a provider to make sure this information was gathered. And of course, the diagnostic results showed leukocytosis of over 15,000. Lipase was through the roof at 1210, an iron gap of 30 with a BUN of 45, creatinine of 3.9. Her bicarb was a low of 19. Her lactic acid was 7.8 and high bilirubin, which my preceptor began to point me to the consistency of acute pancreatitis. CT of the abdomen and the ultrasound confirmed the acute pancreatitis, and also hepatic steatosis and the hypoechogenic head of the pancreas changes to that. On the assessment, of course, acute pancreatitis was the top number one differential diagnosis. However, based on her symptomatology and the labs, it was evident that the patient was probably going through early signs of sepsis, and which probably were being augmented or what's getting complicated was her acute on chronic kidney illness. And of course, her hypertension, probably not well controlled. And the plan, of course, was started in the emergency room with a sepsis bundle. A patient was given 3 liters of fluid resuscitation along with Sofran, Sozin, and Dilaudid. Patient was then, orders were placed to be admitted, and the doctor suggested 48 hours of admission, for reevaluation and treatment. Of course, with continued fluid resuscitation, but now probably at a rate instead of bolus of a rate of 100 millimeters per hour. Of course, classic care for acute pancreatitis is, of course, classic treatment is to place the patient NPO for bowel rest, as well as continue the sepsis bundle, which was started in the emergency room, which included the blood and urine cultures. Also, the patient was started on low pressure at 25 milligrams PO for the sinus tachycardia she was presenting. And of course, in this case, is the doctor, preceptor pointed me to a good bedside manner, if you will, good treatment regimen to include a CWAP protocol for withdrawal symptoms, and an order was placed for PRN Ativan for the patient. And of course, we were to follow up on this patient.